Hello students. So today let us see the topic knee dislocation. It is an injury that occurs when the tibia and fibula are moved out of their normal position in relation to the femur. Also it is called as sometimes patellar dislocation, but here the patellar kneecap is moved out of its position from the patellofemoral groove. So the whole knee joint, the bones are held in place by the ligaments, strong bands of connective tissue, retinaculums, which stabilizes the knee. So when the knee is dislocated, the ligaments tear. Dislocations can occur as a result of contact or non-contact trauma, hyperextension and direct force being the most common mechanisms of injury. Collisions in certain sports such as soccer, rugby, gymnastics, ice hockey frequently results in hyperextensions and the dislocations caused by direct force, which are common in the case of which are more common in the case of motor vehicle accidents and collisions also. For the knee dislocation, we can say that it is a multi-ligament injured knee, and it causes complete joint disruption resulting in loss of contact of the articular surfaces. Subluxation occurs when the articular surfaces stay in contact, and both of these fall under the term multi-ligament injured knee. And it is caused by injury at least 2 out of 4 major knee ligaments like the ACL ligament, anterior cruciate ligament, or the posterior cruciate ligament, lateral collateral ligament, and the medial collateral ligament, normally associated with considerable ligamentous disruption. It causes disruption of the active and passive stabilizers of the knee joint and is often linked with compromise to neurovascular structures and can potentially be sometimes a threatening condition for the limb. So again, if you see the clinical relevant anatomy, the knee joint is made up of articulations of the distal femur, proximal tibia, patella. Ligaments are mainly as I said, the ACL, PCL, LCL, and the MCL. There are two menisci, medial and lateral. Already we have seen the menisci in the previous class. And this picture you can see the quadriceps muscles, the hamstrings, the quadriceps muscle, the quadriceps tendon, and the patella. It rides over, becomes the patellar tendon or the patellar ligament, and this is the tibia. Hamstrings on the lateral side, you will see the continuation as the iliotibial tract, and then the meniscus, which acts as a shock absorber and a cushioning kind of structures in between the knee joint gliding bones. And here in this picture you can see the medial and the lateral meniscus. Muscles already we have mentioned. Then vasculature, femoral artery, mainly popliteal artery, innervation, terminal branches of the following nerves: tibial, femoral, sciatic, medial, lateral, popliteal, common peroneal, cutaneous nerves, posterior lateral, femoral, cutaneous nerves, lateral, sural, cutaneous nerves, saphenous, obturator, and the knee stabilizers, the retinaculum, the medial and lateral retinaculum. The medial acts against the valgus stress. The superficially you have the sartorius, the fascia, the middle side you have the posterior oblique ligament semimembranosus, the medial collateral ligament, the deep joint capsule, medial capsule, and the posterior lateral you have the superficially iliotibial band, biceps femoris, the fascia. Then the middle side, in the middle you have the patellar retinaculum, patellofemoral ligaments, and in the deep you have the lateral collateral ligament, popliteus tendon, popliteofibular ligament, fabulofibular ligament, arcuate ligament, joint capsule. So here you can see this is the picture of a normal knee, the femur, tibia, fibula, the ligaments, the ACL, PCL, and the you have the patella here, and this is the picture where there is the knee dislocation, because here what we see is the knee dislocation, as we have discussed, is we based on the tibial translation in relation to the femur. So here the tibial is turned towards the taking away from the joint towards the medial side, and this is the fibula. Medial collateral ligament is torn this side, and there is the torn anterior cruciate ligament here. What you can see here, it is torn here, and this is the lateral collateral ligament stretched. Etiology: knee dislocation is estimated to be less than the 0.2% of all orthopedic injuries, and complete knee dislocations are rare and usually happen after major trauma, including falls, car injuries, and high-speed injuries. Spontaneous dislocation is often seen in cases associated with obesity, which make up about 20% of the knee dislocations in practice. Knee dislocations can also be present in congenitally and has an incidence of approximately 1 per 1 lakh live births. 40 to 1000 of these cases have additional musculoskeletal anomalies. According to a research article published in 2006, the following percentages are associated with the knee dislocations. So here you can see anterior dislocation about it estimates about 40%, posterior dislocation 33, medial 4, lateral 18, rotatory is 5. So you see the anterior dislocation is the maximum, the highest is 40%. So complete disruption of all the major knee stabilizing ligaments is around 11%. And there are also some complications and vascular disruptions. Knee dislocations are actually classified according to their tibial displacement. The 5 types we have mentioned: anterior, posterior, medial, lateral, and rotatory. Rotatory type can be further classified as anteromedial, anterolateral, posterior-medial, posterolateral. Treatment of the posterolateral dislocations are considered extremely difficult, if not outright impossible, via non-surgical methods. Patellar dislocations occur more frequently than the knee dislocations and are almost always in the lateral side or the outside direction. Already we have discussed about the patella maltracking, and when there is the so as I was saying, the patellar dislocations already we have seen in our previous lectures, that the patella maltracking, or when the patella is easily maltracked or pulled by the tight structures on the lateral side, maybe the tight ITB or the iliotibial band, or the because of the weak vastus medius obliquus, VMO, or the structures middle side, when they become weak, and when the lateral tight structures pull the patella, always have a tendency to pull the patella outwardsly, directed force on the leg. So knee dislocation, high velocity dislocations occur when suddenly and extremely violent force impacts the knee. They are more likely to result in widespread damage to the bones and ligaments. On the other hand, the low velocity are closely associated with sports or athletics, and they typically result in lower rates of vascular damage or damage to tissues. So for this reason, low velocity dislocations have more optimistic prognosis than the high velocity dislocations. Also, there are sometimes iatrogenic vascular injury, that is due to some surgery or when some repair is done. Sometimes the structures are injured. Some common peritoneal nerve injuries, arthrofibrosis, compartment syndrome, traumatic amputation, ligament repair or reconstruction failure, post-traumatic osteoarthritis, development of chronic pain, long-term joint instability, all these things will lead to decreased quality of life. Clinical presentations, we can see in this picture how this patella is uh, moved towards the medial side here, and the most multi-ligament knee injuries are easily reducible with minimal assistance or even spontaneously. Dislocations can be suspected based on the physical examination findings of the joint instability, ligamentous injuries, but also based on hemarthrosis, that is the collection of blood in the joint, and or tenderness to the palpation. It is often difficult to diagnose if a reduced knee was dislocated or subluxed without clinical witness or radiological evidence. Associated meniscal, osteochondral, and neurovascular injuries are often present. The mechanisms are mainly anterior dislocation is hyperextension force, posterior dislocation is anterior posterior force, example dashboard injury. Then medial dislocation, varus force, lateral valgus force, and there is combination called the rotatory force. Also, there is a classification like an acute less than 3 injury weeks post injury, chronic more than 3 weeks post injury. And as I said, there may be some associated injuries like the popliteal artery may be damaged or the common peroneal nerve, that is around 20%. Then vascular injuries 19%, high velocity 65, low velocity 4.8. Then fractures including avulsion, distal femur, proximal tibia, compartment syndrome. Also, classification of knee dislocation are normally positional or anatomical. So as most knees spontaneously reduce, positional classification cannot always be used. There is a classification called the Kennedy classification. Use the position of the tibia in relation to the femur, like anterior, posterior, lateral, medial, rotatory, and the rotatory can be divided into anteromedial, anterolateral, posterior medial, and posterior lateral. This is again a X-ray where you can see the tibia, fibula, and the patella is dislocated from its place towards laterally away from the body, and the femur here you can see. So this is the normal one, and this is the dislocated knee. There is one more classification, the Schenck anatomical classification, which is based on ligament injury, and with additional arterial and neural injuries. Type 1 single cruciate tear, type 2 bicruciate tears without collateral tears, type 3 bicruciate tears with involvement of medial collateral, type 3 lateral collateral and posterior lateral corner, that is the posterior lateral cruciate tear. Then the all four ligaments torn or sometimes fracture with dislocation. So this is the lateral knee dislocation, and this is the posterior knee dislocation, as you can see. It is in diagnostic features, it is very important for us to do a thorough evaluation and make an accurate diagnosis and to exclude any potential associated injuries. Patients normally come in with a complaint of severe pain, instability, limiting activities of daily living and the sports. Very important to do a neurovascular assessment to exclude injuries of the peroneal nerve and the popliteal artery. Mainly we go for the X-rays, the AP and the lateral views, the Doppler ultrasound to assess the blood flow in the arteries, important. Then the ankle brachial index can be used to determine if angiography is needed. Arteriography recommended if there are abnormal findings with the ankle brachial index or any history of ischemia, present signs of ischemic or circulatory compromise. The MR angiography in the acute setting and an alternative to arteriography. Then MRI for more detailed examination and for surgical planning. Examination, it is important to do a repeated evaluation of the neurological and vascular status for the signs of injury, to check any injury to the common peroneal nerve, the popliteal artery, or to assess for the compartmental syndrome. On observation and the unreduced knee swelling, bruising, maybe there is collection of blood hematosis, which can be a major finding. Also, palpation, there will be diffuse pain. You have to check for the pulses, partial presence of dorsalis pedis pulse, that is in the ankle. To rule out the vascular injuries, the range of motion will be decreased, and the ligament testing might be challenging to do in the acute phase because of the knee pain and discomfort, and the patient will not be able to cooperate. And then the PCL and the posterior capsule disruption hyperextension. On passive elevation of the knee, there will be hyperextension. Varus and valgus laxity is tested in full extension, indication of associated capsular disruption. Latchman test, we check to see the laxity present in the anterior posterior directions. Anterior drawer for the ACL and the posterior drawer for the PCL, the pivot shift where the MCL is disrupted, and the dial test where the PCL and the posterior lateral corner involvement and finding into increased external rotation of the tibia is present. Then we have to go for the neural assessment, mostly done to exclude injuries to the common peroneal nerve. Motor power, decreased muscle power of the ankle is a good indication of possible injury to the common peroneal nerve. Sensory, decreased numbness in the presence of an injury is an indication of sensory injury or a sensory nerve injury. There are some outcome measures: the Lystholm score, International Knee Dislocation Score, Multi-Ligament Quality of Life Questionnaire, International Knee Documentation Committee Subjective Knee Form. So these are some scales and forms for the outcome measures. Coming to the medical management, it should be reduced as soon as possible, and after the assessment of vascular status of the leg has been done. Definitive management of acute knee dislocation remains a matter of debate sometimes, because surgical reconstruction of the ligaments has proven to be more beneficial for active patients. Early surgical reconstructions have shown to have better outcomes when looking in knee stiffness and the Lystholm scores. Conservatively, treatment is in a range of motion brace is often applied to give rest to the joint and to restrict the motions. And mainly we go for the vascular repair, like the popliteal artery bypass graft repair with the reverse saphenous vein graft, posterior capsule tear repair. Then the brace, like the exoskeleton donjoskeleton, that is the donjo brace, that is the range of motion brace. Knee spanning external fixator to protect vascular repair if instability is still present. Remaining should be addressed at a later stage, normally 6 to 12 months later. The knee dislocation without a vascular injury primarily repair when swelling permits. If not able to repair the ligaments from the start, capsular and collateral reconstruction should be done. Cruciate reconstruction can be done after 6 to 12 weeks when the capsule is healed. Stabilizer is either a plaster of Paris cast or a range of motion brace. If there is a nerve injury, there is 20% chance of spontaneous recovery after an injury to the common peroneal nerve, usually in cases where the nerve has a short distance damage. Nerve grafting of tibialis posterior tendon transfers can be done to restore dorsiflexion. Other surgical options are percutaneous quadriceps recession. Medial and lateral recessions are made at the superior border of the patella to divide the medial and lateral quadriceps and retinaculum. Knee is then forced into flexion while applying direct forward pressure on the femoral condyles. Another technique is the VY quadriceps plasty. The incision is done in the central part of quadriceps to allow for a V or Y advancement. The iliotibial band is released. Anterior capsule of the knee is divided transversely as far as the collateral ligaments, and the quadriceps muscle is mobilized. Knee is then reduced and flexed to 90 degrees. The lengthened quadriceps is resutured with the knee held at 30 degrees. Manipulation under anesthesia is done in cases where stiffness persists despite therapeutic input after surgical correction. Then there may be congenital knee dislocations. Patients who are diagnosed with knee dislocation at birth are examined within 24 hours. Early conservative management is recommended, consisting of direct reduction under gentle, persistent manual traction. Coming to physiotherapy, treatment depends on the amount of damage to different structures. Each patient will have a different treatment tailored to patient, tailored treatment, and depending on the current stability of the patient, eventually the other associated injuries. The goal is to restore stability and regain pain-free functional mobility. Patients who are limiting range of motion brace to allow to the healing of the capsule and the collateral ligaments. These will restore the varus and valgus stability. During early exercises, wearing a range of motion brace is important to limit flexion to 90° and extension to 45°. After conservative treatment, rehabilitation may begin immediately 6 to 8 weeks initial mobilization. Weight bearing exercises, passive active training of range of motion, muscle strengthening. Then the following can be done as a part of rehab process. Cardiovascular conditioning, upper and mid body exercises along with single leg stationary bicycling. Quadriceps strengthening, very important to prevent patellofemoral problems during rehab. Light manual resistance exercise between 45 to 90°. Biodex machine, that is the isokinetic device. Manual therapy. Leg press machine, more than 8 weeks of rehab. During this phase, the knee needs only minimal protection. These exercises should be followed by high speed exercises with light resistance. Proprioception training is done once range of motion and muscle power has been regained. And post-operatively, surgery aims to restore the anatomical structures with sufficient strength. Passive and active of the range of the assisted range of motion rehabilitation is needed. Most of the patients lose range of motion and do not recover entirely after surgical intervention for a multi-ligament knee injury. So that is why post-operatively the physiotherapy rehabilitation is very much important and very much required to regain the maximum functional position and to regain the strength or the mobility. So thank you, students. This was something about the knee dislocation, and which is commonly combined with the patellar dislocation. And the knee as a whole, we have seen sometimes because of the injury to the structures or the ligaments, the knee is dislocated, which we uh, see in terms of the tibia and fibula movement in or out in relation to the femur along with the patella. Also sometimes only the patella, the kneecap, moves away from the patellofemoral groove, most commonly laterally, and that is called the patella dislocation, which can be uh, sometimes it happens because of injury, sometimes the patellar dislocation happens because of the laxity of the structures, which becomes a recurrent patellar dislocation, and sometimes a habitual patellar dislocation because of any excessive sports activities or the weak structures. The knee patella tends to move away towards the lateral side because of the weak structures of the medial side. So a proper strengthening of the knee structures, the stretching of the tight structures, strengthening of the weak structures, correcting the alignment of the patella, and the correcting the biomechanical alterations or faulty alignments are very much important for the knee injury rehabilitations. So that post in surgery rehabs we are going to discuss when we are going to see in detail the PT management. There are certain protocols week wise, like after the surgery, 0 day, 1 day, and the first week, second week, or the fifth week, seventh week. There are certain kind of exercises prescribed, and there is a different protocol that we are going to see in details in the PT management. So this was about something in short about the clinical picture of the knee dislocations. Hope this video will help you to understand better about this condition, and any doubts please discuss in the WhatsApp group and the Google Classroom. Thank you for watching this video.